All right, everyone, this is our 16th Health Talk, and this topic of discussion today is Medoplex and what we're building. We're going to show a few screenshots and talk about the business model and really what we want this to be and what it could be. So I'll start off by really explaining what it is. Medoplex, you can think of it as an Amazon for healthcare, surgeries, treatments, and procedures. This is really a place where anybody with a healthcare need, and for the sake of this, I'm going to term them as healthcare buyers, can come and find solutions for their needs. And the people who provide those solutions are called healthcare sellers. So we're connecting these healthcare buyers and sellers together on a transparent marketplace where they can transact directly without having insurance in the middle. Really cool concept. Never been done before. Free market medicine is taking off, especially with direct primary care. It's rapidly growing across the country. Not too many people know of it, but it's working. The patients love it, the physicians love it, and the employers that are contracting with them love it. So this model is becoming adopted by more and more past primary care. You're going to your specialist, you're going to surgery centers now are offering direct contracted prices with employers and also imaging centers. They're realizing that billing insurance is a hassle and a headache and it costs a lot, so why don't we just offer a cash price? And these are popping up all across the country. So we're starting to see this growth of direct pay services. So we're building the infrastructure to allow that to scale. And that's what Medoplex is. So I got a few screenshots I want to show to put some of this in context. See, so I'm going to share my screen. I got 4 screens I'm looking at. If you're wondering why my head's going all over the place. All right. You should be able to see this. So now this is a doctor's profile. Now let me back up a little bit and just kind of talk about what this is going to look like initially. We are working with our target market initially is going to be with individuals with high deductible plans and self-funded employers, people who are paying out of pocket directly to these healthcare providers. And the healthcare providers are initially going to be your DPC docs and other physicians that are offering their prices, that want to offer their prices in a transparent manner, surgery centers and imaging facilities. So the idea here is to have the healthcare providers come and create profiles, list, kind of like a LinkedIn profile for a physician. Put in their bio, their education, list out what it is about them that makes them special. And we have capabilities for ratings and reviews from the verified patients, and doctors can list their prices. And that's something that's really, it's just not familiar right now. I mean, everybody knows that. You go to the hospital or to a doctor and you ask, well, how much is this? And the answer is usually depends on your. Well, that causes a lot of the problems in healthcare. So what we want to do is give these healthcare providers the way, the opportunity to list their prices in a competitive manner, whatever price they want to list, and have people purchase them directly from them. And that's what this looks like here. They can list their prices, whatever service they offer. Like I said, we're starting with a handful of specialties, musculoskeletal surgeries and imaging, but that branches off to really anything. This is a new model that's growing, and I mean, this is an experiment. There's no doubt about it. We are everything in the world is experiment, really, if you think about it. But what we're trying to do is foster a free market for healthcare. You've probably heard free market medicine, and that is completely opposite of what we have now. I mean, just for lunch, I was talking with my dad. He had to come up here to get an ultrasound done, and he was telling me about the process he went through. And I'm thinking, I wonder how much his employer paid. He had to get an X-ray, ultrasound, do some lab work, and a visit. I'm thinking that right there probably could have been cut in half at least if you went with a cash-based price. So I'm going to actually see those prices when he does get it, and see what that was. But the idea here is to have plenty of opportunities for us to purchase healthcare services, things that make us healthier, things that we do need at a affordable cost. And not only just limited, or not only have the availability for affordable cost, but also find the right healthcare provider for you. We kind of talked about the eHarmony for the patient-physician relationship. We talked about that at our team meeting this morning, where you can find the right person for you, the right facility for you. You might have certain values that you're looking for, such as certain ratings, certain efficiency levels at the clinic, certain whatever you're looking for. We're going to have extensive filters where you can filter that based on your values. Really neat concept. And let me just kind of run through some more screenshots here. So this would be an example of starting for a search. When you do come to this website, Medoplex, you're going to start by, you're going to have a silhouette of a human. You see it up there. And basically select what hurts or what you need work, where you need something done at. And then we're going to return a list of things that are in that general vicinity. Then you can break it down based on what you're looking for. And then from that, you can filter out or sort through the prices you want based on the amount you want to pay, based on the location near you or wherever you're looking for this location. So the idea here is to really find value. And just like you're shopping on Amazon for anything, I mean, probably just like me, you just go to whatever you're looking for, select 4 stars or better, and just scroll down and pick from there. Kind of the same concept here. A lot of things in medicine can be commoditized. When you do that, you do open up competitive markets. But a lot of things aren't. So there's going to be a lot of opportunities for different specialties to work together. And that's one thing that I really think we're going to solve a major pain point for physicians, for DPC physicians, is the referral process. Because I know the first handful of DPC doctors we're talking to, they need to refer their patients out to specialists. But the problem is, the specialists around them are still playing this insurance game, so their patients aren't going to connect with that, because the patients want to know up front how much this price is. And if you're part of a hospital network or you're part of a under insurance contracts, you just don't know. You can't list that. So we're allowing primary care physicians to go out there and create their own direct pay networks. So they can bring on a cardiologist, GI, imaging, surgery centers, and really create their own network of cash pay or subscription-based physicians. So there's a lot of things in here that will allow this model to scale, and especially we're alleviating a lot of pain points for your DPC docs out there. So that was kind of a somewhat overview. There's a lot of other things I want to talk about. I just kind of wanted to hit on the top. But now I will open it up for any conversations, anything that you see that you like, any place you think we should go, what direction. Just open up for discussion. Hello, is anybody there?
Yeah, I'm just trying to articulate what I want to say.
Yeah, I have to minimize all my screens here. Let me, this is, like I said, this is something new. It's not just a simple marketplace either. We're looking at market networks. There's a good blog post about market networks. Let me share that real fast. It will shed some light onto what we're thinking. You can read this later and go down some rabbit holes reading this.
Yeah, I'm partnered with these guys. They're kind of separate. They're like me. I just have a virtual company. They've got 28,000 providers and specialists. I think maybe connecting me with them, maybe there could be some kind of synergy there. To get,
perfect.
to get people, to get, maybe, I don't know, I can't think it through right now, but there could be a really good possibility of a lot of things that you guys could do together. and then also integrating with my platform. I think it would be great, if someone needs a shoulder surgery or something of that effect, and then it just flow right through from the GoMD platform to the Medoplex. We could work something out, and then vice versa. I mean, if there's some of those physicians out there, and I know the DPC, it's really just in its early stages, and a lot of the physicians out there are really interested in building their what's called telemedicine presence. I call it virtual health, just to change it up. Investors don't like the word telemedicine anymore, I guess, so I had to change it.
Yeah, I'm to the point now where I think we should just drop the electronic from everything, drop the tele and the virtual from everything, because just like we're doing now, pretty much if you run a business in 2018, you're going to communicate via text message, phone calls, email, Slack, video. I mean, that's just how you operate. And
Right.
I don't think healthcare should. It's just the common sense way of doing things.
So so I guess my next question, where does the blockchain come into?
Sure. Okay. So with traditional billing, you have a physician that has a service they can perform. And when they do perform that service, they input a code and submit to insurance. They submit a claim. And then they get paid 45, 90 days later, might get paid, probably some haggling back and forth, big headache. So we're allowing them to take that service, and before they bill it, they actually tokenize that in the form of a health service token. And this is a non-fungible token. And the physician can say, well, this is the service I can perform. Let me put my terms and conditions into this. Now let me put it up for sale on the marketplace. And this is my price. This is what I want to do. If you want my service, you can buy it directly. We don't need to deal with insurance. So that right there, there's other things we can do with that. If you think of from a self-funded employer, just say you have 1,000 employees and you go out there and you do want to purchase 10 knee surgeries, 3 back surgeries, 37 dermatology visits, and just whatever you might need, you think in the course of a year, you can customize your plan and purchase these time slots and services, procedures from these physicians. And if you don't need them halfway through the year, you might realize, well, we're actually on track to only do 1 knee surgery this year. You can turn around and resell those back into the marketplace. So you're not going to be stuck with losing all your money. You can sell it to somebody else, and that physician is still going to get paid.
Right.
So that's we're trying to get away from talking about blockchain and crypto when we start explaining this stuff, because for one, it scares people if all they hear about is the negative side of Bitcoin and cryptocurrencies.
Right.
And if you're biased, you're immediately going to jump to that bias and think negatively. So, I'm to the point now where I just accept that blockchain is just another technology. When we develop apps, we don't say, oh yeah, this is built with MongoDB or PHP or Ruby on Rails. It's a given. It's just there. So I think that's how this technology will be moving forward. There's a lot of hype around it now or in the past couple of years, but moving forward, I think it's just going to be a new way of doing things. Since you asked, we'll hop back in there. Now with Humantive, that app we were talking about to begin with, download that and you connect a Fitbit, Apple Watch, wearables of your choosing, and we incentivize you to go do healthy things. So we're tracking your steps, your sleep, and your activity throughout the day and your heart rate. And when you do improve those, when you hit certain metrics, you earn a unit of value called Medit. And this is our cryptocurrency. This is the ERC20 token. Think of it as an incentive token. And you can use this to offset your purchases on Medoplex. For instance, we're going to start off with, say if this procedure is $100, you can pay $90 with cash and 10% with Medit. So it's going to be like a discount. You can think of it as a discount token. So by being healthy, you get a discount for your health services.
Right.
And then that's from the purchasing side. On the selling side, the physicians, we're looking at a model where all physicians are going to have a stake in this network. So they're actually going to have equity ownership in Citizen Health. almost like you think about a node in the network. They'd be staking a node in the network with their equity, and credentialed physicians can take that and met it that they do accept for payment, and only them can convert it into Medix, which is our security token. So they
Okay.
can convert that into equity, essentially, and then with that, by holding Medix tokens, they can receive dividends from all the transactions on Medoplex, because there is going to be a transaction fee that for everything that happens on Medoplex. Haven't really
Mhm.
agreed on exactly what that is, but look at Visa or MasterCard, you got 2.9%. So it's going to be a charge similar to that. And half of that or some percentage of this will be distributed to all the Medix token holders. So all the physicians, all the investors in the network will get dividends, monthly, every 6 months, whatever we all agree on, all the token holders agree on. Because what we're trying to do here is really to create a very large organization that is governed by the token holders. So not your traditional company that has 3 or 4 people at the top making deals, in back rooms, under the table, stuff like that. But really have the intelligence and the wisdom of the crowd come together and make these decisions. Because we are trying to build something huge that works for everyone. So we need the insight from everyone to make it happen. So it's a completely different model.
Yeah, that sounds great.
Yeah, but to get back to your point you talked about earlier, some thousands of doctors, that's really what we're trying to do. If you think about Sermo or Doximity, you have a couple social networks for physicians. Nobody's challenged those guys. I don't know why. I just don't know why. I'm not saying we are going to do that, but what I'm saying is what we are doing, it looks to be like that. We are creating a network for physicians to create their own networks, their own pay networks. And with that, there will be communication. And that's our first phase is to kind of what you saw here, to get this launched and what we talked about, the initial target markets, get those launched. In the next phase, probably second quarter of 2019, start on the scheduling piece. So where a patient can go say, I want this knee surgery on this date at this time, and purchase that directly with that time slot. And also have the communication features where the doctor can communicate directly with the patient. You can share images, videos, just have an asynchronous form of communication there. And then payments as well. We have to own payments. So subscription-based models, just pay through the platform, really having scheduling, payments, and communication as the building blocks on to really scale this out. I think that's what's going to give us the advantage over, give us a very special advantage. So there's a lot of things that can come out of this. Like I said, you can have something like a Wikipedia for healthcare that I'm really excited about that. I mean, think about a lot of people Google health related issues, and there's so many just garbage websites out there, people with opinions, but people read that and they think, oh, I have cancer. And you've heard those stories. So even off Wikipedia, we don't know that that's correct. And I would love to see a verified source of truth for all things healthcare. Have physicians, have people publish their thoughts and their knowledge and have it peer reviewed by other physicians, kind of like Wikipedia for healthcare. If you really want to get down to it, a Stack Overflow Wikipedia for healthcare.
Yeah. I thought about that as well. I thought about that as well, like about a year ago. There was a company I went to, but we couldn't come to any kind of agreement. But the way I envisioned it was kind of like a Facebook for healthcare, where you can type in the search bar and you'll get all the top ones. If something had 1,000 likes versus something had 900 likes, you would get in that kind of order, because the more likes or approvals maybe is what you're thinking, from maybe people that are governed to be able to make approvals, like doctors and stuff, and so those things would come higher up on the list into your news feed for health or whatever, So yeah, that's a great idea.
Yeah, I really do think the internet needs something like this. I mean, I've been thinking about this idea for a long time, the past 8 or 9 years, and It's a personal want. Like I want something out there, and nobody's done it yet. And once again, I'm not saying we're setting out to do that, but we have a great opportunity to do that.
It's big. It's really big. That's the thing. It's just really big.
Yeah. But we are creating this network, and it's hard to think about it this way. A lot of companies, you're creating software products, but what we're really creating is a network. We're creating the software products to create a network. And with network effects, I know I never did find that article, but talking about network markets, it's really you have a network of people that are working together to solve problems, and you have the tools to allow them to solve those problems. And it really creates something amazing. And nobody's done that in healthcare. So it's something we need, and especially you start looking at all your, there's a lot of published studies out there that are, yes, that one, Connor, that one. Really good article. You're muted.
You're muted. Oh, my video's off.
I printed it on paper. I'm so high tech.
Old school. My printer broke a long time ago, so I gave it up. So you think about all the published studies out there that are biased. I mean, if you have a pharmaceutical company paying you to do this research, I mean, come on, which way you're going to lean. And I feel that there's a lot of published studies out there that lean one way or the other.
Yeah.
I mean, that's my opinion. It's not necessarily my opinion. I do feel that way, but I feel like it's probably more prominent than we think. And that's scary. It really is. So having something that is decentralized in a sense, that is governed by the community, you don't have one centralized authority figure that's pushing the buttons, but you allow it to self-organize. That's something that we're looking at. That's the infrastructure we're setting up to build something like that. So we have 1 million physicians out there. We have a long ways to go.
Yeah.
But Raymond, I'd love to talk more about that, and also on telemedicine. I think this is a good opportunity to get physicians on here that do have free time. Almost, you can think of it like Uber. If you're an Uber driver, oh, great, I got 2 hours between 3 p.m. to 5 p.m. Let me turn on my Uber app, and I'm open for business. So same thing with a physician. Oh, you know what? I have a couple time slots that are nobody's booked, so let me be open for telemedicine visits or virtual visits or video visits. And
yeah, we can do a lot of things. I just hired. He's gonna be the lead doctor for my Spanish version of GoMD, which I'm gonna hopefully roll out here in the next 3 months or so after everything gets translated. The main system itself, the portal and the EHR, is in 36 languages because my vision is to be kind of global. But definitely here in America, there's a huge need, for the Spanish community, Spanish speaking community. So I'd like to see hear what your thoughts are on, have you thought about, the bilingual doctors, and is that integrated in your system right now? Because that could be big,
Yeah, thought about that. It's not integrated yet. I wouldn't say that it's that difficult to go down that road. I will say we've had a lot of interest from outside the country, outside of the United States. I talked to somebody about a foundation there soliciting proposals for a kind of something like Citizen Health, like what we're doing, just a new style of direct payment model for healthcare. And they're in a handful of large Latin American countries. So that's going to be around February, March that I'll follow back up with that. But yeah, the opportunity is out there. Like, the United States is the hard country. There's a lot of other countries that are a whole lot easier to launch this in.
Sure.
We have global thoughts too, global plans.
So yeah, I think we're gonna have some good talks. Yeah. So is it okay if I post my website if anyone wants to see it?
Sure. Yeah. Go ahead.
Okay, I'll type it in there. You can check it out later. I'm gonna click on this too. Yeah, I think you have a really great idea going on, and that's cool how you're making the contracts with the blockchain technology. I've written a couple of tokens. I just dabble in it. I don't really code that much anymore. I'm more of a get people to code for me. So I've got a team in India, a couple guys in Detroit, California. 90% of my company, I've never met them in real life.
That kind of goes for us too.
Yeah, it's funny. I just know all their digital selves. So yeah, it's interesting, what we can do now with the technology. I started doing remote work. Like I told you, my first job was in Dusseldorf, Germany, writing supply chain software. And I'd come back to Colorado, and we were doing remote work through dial-up. I mean, that's how far it doesn't seem that long ago, but sure enough, that was the beginning for me, is sending a file which would take like 15 minutes to get to Germany. They'd send one back, I'd be waiting a half hour. It's funny how how everything's gotten so fast.
The evolution of our software is just incredible, and the components of what we can do now. I mean, we're at the gateway of the internet in 1996. This is where we are with the blockchain, but now what we can do with healthcare. So Brennan, too, maybe you can describe a little bit about, I'm a doctor, and maybe I've thought about DPC, but I'm kind of in the middle of this. How could I really grab a hold of the Medoplex and Citizen Health? What could I do, and how could I come into this organization and make this something that I could use for my practice and my patients? Can you describe a little bit about that?
Sure. Check the attendee panel. Yeah, so one of our first pilot programs is going to be with New Care MD in Jackson, Mississippi. And what I mentioned earlier, hey Matthew, you're muted. But what I was mentioning earlier is they have a problem with referring their patients out to specialists. And let me back it up a little bit. So when these DPC doctors transition from that insurance-based practice to this subscription-based practice, it's like a gym membership. So now that EHR that they had, it's not really relevant to their practice now. So they have to rethink how to manage the patient. And if you think about the patient is now almost like a project. So you kind of almost have a project management app out there. Think about it that way. And we are building something that we're calling a health operating system. It's a way for these physicians to really kind of evolution of EHR, a better way to manage the patient's health and be on top of things and collaborate with the patient and the caregivers and other specialists. But for now, when the physician does come over to this model, they're going to need the way to bill patients. First and foremost, you got to get paid. So you have to have a subscription part to this system, which is something we are developing. And also just a way to accept credit cards and get paid directly, because you're no longer putting in your code to submit claims. You're working on your own pricing. So that's one thing that we're going to have to work with physicians, is figuring out your price. Because a lot of times physicians, they don't even know what they're worth, because it's essentially you're selling your time. That's what you're doing. So figuring that out, there's a lot of trial and error that's going on out there. People are figuring out there's high ends and low ends. It really depends on your target market, who you're going after, and really just what you value your time at. So working with physicians to get their prices transparent, list them on there where it does reflect the adequate value that they're trying to portray, or people that are looking for. And then having ways where they can accept that money from the patients or the self-funded employers. And then on top of that, having a scheduling system in place. Because if you are doing the subscription model and you really one physician in one practice, you have to figure out your time slots. So on average, I'm seeing about most DPC physicians, you're looking at 1 an hour. One, work 8-hour, 10-hour days, so 10 a day, and you schedule these hour slots. And you can sit down there and talk with your patient for 45 minutes, an hour, to really figure out that root cause of their problems. So having that scheduling system in place where patients can, through their app, they can register for an appointment tomorrow at 3 p.m. And if they are a new patient, and this is really big, they won't have to input all their data if they already have Humana. So they're going to have all their health records. That'd be great. But having the payment module, the scheduling module, and also having the ability to communicate with your patients. Because once that initial relationship is formed, there's a lot of things that can be done outside of the doctor's office. You're looking at telemedicine, and it's not just video. It's text messaging. We talked about earlier, in business, you're communicating on a lot of different formats. And it's something as simple as, "Hey doc, is this okay?" And you text them and they say, "Yeah, you're fine," or "No, you might need to come in." And you can save a lot of time and a lot of money doing it that way. And there's Jay Parkinson had a nice talk at Exponential Medicine Conference about synchronous and asynchronous communication. And it really shed a lot of light into how we can expedite or maximize the physician's time. I think that's what it comes down to. A lot of people say we have a shortage of physicians out there. No, I don't think we're utilizing our time correctly. And just be smarter about how we work or how physicians work, and really maximize the availability that they have. So
shortage in the current model.
Yeah. So having those things in place, the scheduling piece, the billing piece, the communications piece, and then add in our health operating system, a way where you can see all that data, all the health data on the patient, and visualize what the problem is, what current problem they have, and how's it trending, what does it look like. Then also have, AI, have some additions in here to start really augmenting your intelligence. People say that AI is going to replace physicians. Yeah, that's probably going to happen 30 years from now, but 30 years from now, it's a completely different world. So in the meantime, the next 10 to 15, 20 years, AI is going to play a huge role in augmenting the physician in the practice. For instance, there's no possible way a human can read all the PubMed articles. Just no way. So having an AI constantly looking for scenarios that could benefit this conversation with the patient that you're currently talking to right then displaying it on your big screen right there. That's something that's not really possible, or hasn't been possible, but now it is. So this is what I was talking about, the health operating system, a new way to collaborate with your patient on their health. So you can bring in other specialists, bring in the caregivers, bring on the patient. We can all communicate in real time or just kind of over time, and figure a way to get that patient back to baseline if they are unhealthy, or figure out what problem they are trying to solve and work together to solve it. So all these pieces are part of the puzzle to fix or to build this new direct pay, calling it health as a service model, for not only direct primary care, but every physician out there and every healthcare professional that just is tired of insurance. And Matthew, I think you're muted. Yeah, you're muted again. Oh, you're muted again. There we go.
Am I there?
Yeah.
Could I throw something in there? Just comment about physician practice and price transparency.
Yeah.
So I would say that right now, for the most part, physicians are not aware of the prices that are being charged to the patient.
Absolutely correct.
As a general rule, if, say, someone comes in and they're a little bit sick and you're considering a white count and a renal panel, there is never a discussion of, it would be nice to get this, but this is $20 and this is $40. We probably only need this. Those discussions generally are not being had. The one exception is on very high-end things.
The idea about being a virtualist.
Periodically, when we had a high-end test like an MRI and someone without insurance, then we'd really have to get into the nitty-gritty numbers. But it was hard, even in a very well-run hospital or very well-run system. It's not trivial to say, this is the cost of an MRI with contrast of your brain, you know, and be able to kind of, this is what we're going to charge you. So just that one thing, having price transparency available while you see a patient who may be partially self-pay, partially insurance, is huge. And, I'm sure there are some places that are doing that, but I'd say 99% of us are not having a price discussion with the patient 99% of the time.
I'm partnered with a group out of I think they're in Houston, and they offer those exact things: MRIs, CAT scans, and they have a price list. You just put in your zip code, and then you can see the nearest place to go get one. And I think their MRIs are really cheap, like $300. So if you want me to, you know, you could take down my email or something, and I could show you how that works.
Yeah, it's very similar to what we're doing too. And I got some quick math over here. On average, about 600,000 MRIs performed every year in this country. I saw between 600 to 750,000, but let's just go with the low number, 600,000. No, I'm sorry, that was knee surgeries. I didn't specify. 36 million MRIs every single year. The average MRI in the United States is around $2,000. So we're looking at $72 billion spent just on MRIs. Okay, if we did operate in a fully transparent market where people could shop around and pick the lowest cost MRIs, Green Imaging is going to be one of our first pilots as well. They offer MRIs with contrast for $250. So multiply that by 36 million, it's $9 billion. So what is that? 63 billion that we saved. Guess what? That eliminates homelessness in America with the amount we saved. It's just simple math that having these large differences in price from literally one street over causes a whole lot of problems in healthcare. And just for instance, also knee surgeries. I use MRI and knee surgery as a common example. We have about 600,000 total knee replacements every year. And with the aging populations, estimated it's going to be about 3 million complete knee replacements by 2030. So not very far away, but that's a big increase. The average cost right now is about $49,000. So you're looking at $29 billion for those knee surgeries. But if you go to the Surgery Center of Oklahoma, you get one right now, $15,499. Just round it up to $20,000. That's $12 billion. We're saving $17 billion by going direct pricing model, cutting out that insurance and just going direct. And you multiply that across the board, that's where we start saving that $1.5 trillion that I always talk about. And it's just being smart with our money, because if something out there is cheaper, cheaper in the same quality, why not purchase it? Well, people just don't know about it. So what we are trying to do is let people know about it. And it's a work in progress. And Matthew, it's going to be hard, working with the physicians to figure that price out. It's not like a physician can just go to their the insurance biller at the hospital or the system and say, hey, how much does this cost? There's going to have to be a lot of discussion around this and how we do this. But I do think once a handful of physicians out there, they start listening to prices, people will copy them and go up or down based on part of the country they're in and wherever they see value. So I think once a handful of people figure it out, it's going to start spreading. It's still a change of thinking. It's a paradigm shift. Luckily, we have a lot of self-funded employers that are making this shift for half the country. And about 1 out of every 2 people in this country get their health benefits from an employer. And increasingly so, these employers are getting away from being fully insured and dropping the TPA and really just starting to write their own checks. With the prices going up, they have to figure out something. So we really want to allow the self-funded employers ways to directly contract with the physicians in their area, ones that can bring them higher value, higher quality care, at affordable cost. So really save the employers money on their employees' healthcare cost, and then, you know, in an ideal world, that would equate to a higher salary for their employees and everybody happier and healthier. That's the idea, at least. Whether employers do that.
Yeah, Brennan, higher salaries, but also just better benefits, better care.
Yeah.
I mean, you know, that's the thing about the self-funded piece is, you know, the quality of healthcare really typically goes up. They become better consumers of their healthcare, and, you know, you start generating that, you know, trend and start nudging them in that direction. It, you know, it forces them, not forces them to, but it, you know, inherently will make them become better consumers when they start looking at these opportunities. Oh, this is cheaper, it's better quality. Why would I not do that? Right. And, you know, and you know, so then the company saves all this money. Well, you know, hey, you know, we're getting a 10% increase. Well, you know, if you're $5 million spend on healthcare every year, I mean, 10% is a lot, right? You know, so hey, you got $500,000 going out the door every year. Let's bring now. What if you cut that out? What can you do with $500,000? Make better benefits. You know, negotiate better contracts with some of these other people. I mean, it's what can you give to your employees that you previously weren't?
Yeah, exactly.
That's the value I see in it.
You know,
Are the people practicing direct primary care, do they have a mixed practice where half their patients are direct primary care and half are typical insurance?
Yes.
That probably goes out to John, I think. But.
Yeah, the majority of the pure DPC practices do not take insurance. And for the primary reason that taking insurance and doing DPC, you still have to have personnel and space to house that personnel, and you have to have all that hassle of filing insurance and getting denied and pre-authorizations. So the majority of the DPC docs that I know don't take any insurance at all. Those that do are called hybrid practices, and or then there's the pure concierge who doesn't do DPC typically. They do offer longer appointment times, but also they charge a much higher fee.
And are they seeing 8 patients, 10 patients a day? Is that their volume?
I think the hybrids probably see more, because in order to do anything with their insurance part, they have to see a number of patients to be able to file enough claims. And the other thing is it's a hassle if you do both outside of just the insurance part. You're having to time yourself to see 4 patients an hour on the insurance side and 1 patient an hour or every 45 minutes on the DPC side. Dr. Wax, welcome. You're muted by default. So, and perfect timing, Dr. Wax is here, who can certainly shed some light on that question. Dr. Wax, Matthew Rarrell was asking about DPC docs. Do they see insurance patients? You know, half and half, and I was explaining that the majority of DPC docs do not see insured patients as a rule. I guess I shouldn't have fired right off to him when he showed up, right?
Yeah, we can't. I can't hear him. Can you guys hear him?
yeah,
No,
we can't hear you.
Still, his mic's not working.
Yeah, you're not muted. We just can't hear you. No, it might be going through a headset somewhere. Might be connected to a Bluetooth headset somewhere. No. You might can try turning off your Bluetooth.
Well, one other thing while we're sorting that out, I'll comment on, is 1 patient an hour is fabulous. I mean, that's an entirely different visit than 4 patients or 6 or 8 patients an hour. So those are entirely different experiences for the patient and the provider and the physician.
And I think the beauty of it is that the majority of those 1-hour visits are initial visits if they're new patients.
Mhm.
Because 70% of the visits in a DPC practice can be handled. I know we weren't going to use the word electronic anymore, but they can be handled outside of the office. There are 30% of those visits that require patients to actually be face-to-face, or if the patient wants to be face-to-face, obviously.
This is Matthew. Dr. Rule, from a business standpoint, from a consumer business standpoint, obviously, the more access you have, the better in the long run your healthcare costs will be. Just to let you know, there is a ton of information from how DPC directly impacts these healthcare costs. DPC has a massive reputation at doing this. I know Dr. Wax can definitely give you some great information on that, as well as Dr. Brian Forrest, who has kind of become a evangelist and pioneer for the whole model as well. So both of them have some great information and proven information that can prove that. Just to let you know as well, companies are demanding this. Companies are begging for DPC. They want it because of the access. And they know, and they're smart enough to know, that when they partner with a DPC provider, plus a provider that also has telehealth, hence Ray, then they know that those healthcare costs will drop for their company. So John and I are right now in contact with some very interesting companies, to say the least, and they are wanting this badly. They are wanting providers that can do this, and they're desperate to find them. I can tell you right now that there is a very large platform that was created by Twin Oaks and Acressa. And this is a platform that has over 8,000 providers in it right now. And this is a mixture of DPC and John, help me here, I think they're hybrid practices. But they have come together to create this at the demands of these large companies that are wanting DPC. So what's going on is that Acressa and Twin Oaks created this platform that allows for the companies to do exactly this. They can go onto that platform and search for a provider directly near them that is doing this.
Hopefully my mic is working whenever there's a break.
Yeah,
There it is.
loud and clear.
Yay.
Working.
Okay. Well, I just got done doing a few radio shows, so I've got no lack of speech.
Well, to circle back with Dr. Rail's question about, I guess, the average DPC physician out there, how many patients do you see in a day, do you think?
Well, you know, the average DPC versus concierge, there's some primary differences, and I'm sorry to have joined late. I apologize for
I'm glad to have
scheduling
you.
and technical issues. Thank you. So DPC tends to be direct patient care, tends to see maybe 10 patients a day. I want to say something like that with regard to half an hour visits or an hour, depending on what's necessary, where the patient is the sole payer. They reject insurance, they reject government programs, whereas concierge models are different. That is to say, like the MD VIP model and some of the others, where you accept insurance and also charge a monthly fee. So I don't want to say double dipping, but you're sort of like getting it on both sides. And a lot of patients get frustrated with that because they feel like, well, you're charging me $100 a month and you're charging me copays and deductibles and those kinds of things. So there's a lot of issues to go, and there's every possible combination of those things. So there have been hybrid DPC and concierge and regular insurance practices. My practice is primarily insurance and moving toward DPC. That's the direction that I'm choosing to take. So it's a challenge in moving from a revenue stream where you have insurance and government, what have you, involved, to a revenue stream where it's direct patient care, because you have to offer them not just more time, but you have to offer them more value. Like, can you resell medications for pennies? In the state of New Jersey, you can't, but in the state of Pennsylvania, you can, for example. So to circle back to your question, concierge people might see 6 patients a day, DPC people might see 10 patients a day, and insurance people could see, between 20 to 30 a day.
How on DPC patients do you handle hospitalizations?
So that's a good question. I mean, I don't think any DPC physician will tell you, reject insurance completely and don't have any sort of catastrophic coverage. In fact, on our wish list for this holiday season is to have a lot of the restrictions of ACA and other government rules that force insurances to be certain things and not to be other things, be more along the lines of catastrophic care. So that's probably how the hospital and stuff would be handled. The idea behind DPC specifically is kind of like everything you need for your day-to-day, except not necessarily the things you might need for a catastrophic occurrence like an appendicitis or something like that. Most DPCs, though, do small amounts of surgery, obviously not peritoneal surgery or something like that, but they do small skin surgeries and things like that that are more in the everyday line of things.
So one of your patient markets would be patients with high deductible ACA plans. The patient with $6,000 upfront copays, and they don't want to spend that much in a given year.
Right, and with DPC, they could spend perhaps between $800 and $1,000 and get all of their needs paid for. It's hard because everybody's been kind of sold this model of you get a job or you get on a government program, you get a card and it entitles you to unlimited rentals of whatever the movies are. And that's always hard because some movies are more expensive or more expensive to make or what have you, just to use that as an analogy. But the idea behind DPC is to do everything you need for between $600 to $1,000 per patient per year on any given day. I mean, it's all the oil changes, it's the tire rotations, it's the brake jobs, it's all that stuff. Whereas it's not like major catastrophic accidents, to use an auto analogy.
I think another thing that's important is, and it sometimes gets lost because we're talking about the details, is the idea, again, another idea behind DPC is to really try your best to keep patients out of the hospital to begin with.
Sure.
Really
well, that's certainly the
health.
motivation, and it does also fit well with the ACA, with the plans that are. I'm blocking on the name of them, that are somewhat religiously affiliated and immune to ACA. The
health sharing plans.
Health sharing plans.
Right.
So with a health sharing plan, assuming you have coverage for catastrophic things and some ability for someone to negotiate on your behalf, that plus a DPC would also be an ideal current situation for someone that values their own health. I mean, that's the hard part, is people just expect their body to run forever. It's like buying a good car. I mean, you have expectations that it'll run for a long time, but you also have expectations of caring for it quarterly. Whereas the body, people tend to think of as, superhero-ness, where you don't have to do basic things. And it's an education process of patients, because you have to sell them that they're that important, that they are worth $60, $80, $100 a month, and a lot of people think, well, I can't afford that. But meanwhile, they're buying cigarettes, they're buying alcohol, they're buying fast food, they're paying for, expensive computer toys, lots of other things.
Yeah, health is our most valuable asset. We don't treat it like that very often. Dr. Wax, when you have to refer patients out to specialists, what's the best way to do that? Because I know a lot of specialists are part of hospital systems.
Well, that's another question. I mean, I use a lot of independent folks, and with a DPC model specifically, if they have other insurance, then you may have to play ball with the insurance network sort of thing. Or if they have Medicare or Medicaid or something, there may be some other limitations of that. But personally, I've developed over the last 10 years a network of physicians who will see patients for relatively inexpensive amounts, like a specialist consult that might cost $300, $350. I can get for $125. And the labs, of course, I'm sure you're familiar with, you can get Medicare rates or better just if you bargain with the labs.
Yeah,
I think part of that is that you don't have to file insurance if you take cash. And so the specialists probably see that as less of a hassle.
Well, the thing is you have to tell the specialists and the imaging people. I have a local imaging center that will do a $1,200 MRI for $350, and they'll do them all day long if they can get it.
Yep, absolutely.
Yeah.
Are you allowed to not accept a patient just because they might be too complex, or do they self-select a healthy patient population for DPC?
Well, that's a great question. I like patients to self-select. I mean, they will select and deselect at will, as I'm sure you know, and that also goes for insurance patients or Medicare patients or what have you. Someone chooses for a multitude of reasons. But having said that, sometimes, and it's not necessarily due to complexity. I mean, being a family doctor, my job is to either provide 90% of the care or coordinate the care of others that's provided for things I can't do, like surgeries or cardiac catheterizations and those kinds of things. So it's possible, and I think that each physician, just like each patient, has the right to select or deselect. I mean, it's almost like a marriage. You get into this relationship with an understanding, and into the relationship, you might decide that the understanding has changed, or that the understanding isn't being valued by both sides. Or, I mean, I've had patients be rough with my staff and things like that. And I've told them, I'm happy to help you. We wish to be respected. We want to respect you as well. So this is kind of the code of conduct around here. We treat you like gold and you treat us with respect. And then, we get along. I don't really ever deselect a patient due to complexity or disease state or what have you. I mean, there's hospice for those. I mean, when the hope component has waned.
You mentioned a good point there, care coordination. And that's something I think is big in the DPC community. And when you do have to refer your patient out to have all these procedures done, having all that data that's generated from that coming together on one platform. Is there a way that your current technology stack that you collaborate with all those entities involved in that?
Well, it's interesting because I don't know if you've ever Googled some of the things I've spoke about across the country for the last 10 years, but I am a huge adversary of EHR and the way the government has rolled it all out. A huge adversary. I've got a big S on my chest and fly around sometimes using analog strings just to fly around. But when I coordinate care, I usually coordinate it in front of the patient, and the office staff will get things, or I will call other physicians, or God forbid someone is diagnosed with cancer and I have to tell them. I text a specialist nearby and I say, hey, can you see this person tomorrow? And they say yes or no or whatever. And patients really notice that. I mean, that's what the relationship is about. It's a trust relationship, and it's a level of coordination and communication that I think is worth paying for, because the current crop of physicians that's coming out now, I don't see them as physicians. I see them as technicians. They're people that can do their little piece in their moment given, and that's it. But they're not the person coordinating their end of the relationship. They're not coordinating the care. They're not trying to help someone achieve health. And that's one thing that makes us unique, maybe, is that we help people seek health. I mean, the founder of the DO profession, Andrew Taylor Still, who was an MD and a DO, and the profession started about 130 years ago. But at any rate, he said, seek health, anyone can find disease. And I think that's part and parcel of the phenomenon.
I love it. I love it. Adding to that, and I do apologize when I sent you that message last night. I guess it was right before midnight around that time. So,
well, it was funny. Tomorrow was about 30 minutes away, and when I saw it today, I didn't realize that tomorrow was today. Sorry,
yeah.
I apologize too.
Yeah. So we should have another conversation with some DPC physicians and people that want to promote free market medicine to kind of continue discussion, because I think we are building the solutions that you just mentioned there. Sum up what we talked about, the initial part of this. Medoplex is really a marketplace for free market healthcare where people can transact directly without insurance. I'm completely against insurance. We stand for the same thing, and also EHR, done with those. But we want to give physicians the opportunity to list their prices transparently, and have a way to accept payment, subscription-based payment plans, ways to accept payments, and also scheduling software to schedule these patients, and also a communications platform where you can communicate with the patient via text.
Well, let me ask a question based on that. I appreciate the coordination efforts and the judicious use of technology, let's say. We have an interesting feature at our practice that's worth paying for, and people really appreciate it. When someone calls our office on the phone, we answer the phone. There's a human. And then the human says, oh, hi, thanks for calling Dr. Wax's office. How can I help you? What can I do for you? And then gives them lots of different options with regard to care, and may provide some information on our background or what have you. But the human component is really, really important to DPC, I think, and to any physician relationship. The other thing is machines can't schedule a patient like a human can, because the human knows that, oh, okay, so this is a new patient, so you'll need a half an hour, or this is a gynecologic exam, you'll need a half an hour, or a routine physical, which is at least a half an hour, versus like, oh, okay, you have a sinus infection and, the over-the-counter remedies aren't working, and maybe that's 15 minutes.
I'd like to just follow through.
Let me just throw out there that people often don't know what they need with regard to time, and that's a valuable service that we provide. Obviously it kind of goes along with everything else that, they'll come in and they'll say, oh, I need X. And then they'll get into the room and they need Y and Z. And then if we can possibly provide it, we do. Otherwise, we have to schedule more time.
I'd like to follow through with something Dr. Wax alluded to about his Superman against the EHRs. So I would say, I've seen about 30 to 40,000 patients with paper charts and maybe 60,000 with EHRs, something like that. And I'm probably a little bit more ambivalent, but my sense with the EHR before and after is EHRs have certain benefits, certain technical benefits at times, particularly for complex patients. But the cost associated with electronic health records retrospectively is there is a dehumanization of the actual patient. So the center of gravity is moved towards these EHRs as opposed to the patient. Although people talk about patient-centered care, I would contend that we have actually EHR-centered care. And the systems that have bought into EHRs, they tout the benefits, but they haven't yet accepted the fact that there's
I think your sound dropped out.
Frustration with electronic health records from the physicians and the patients. So that's my take with Dr. Wax. So he's
Dr. Wax and I do a little communication on Twitter, and I renamed the EHR the ERR, which has some computer science connotations as well as
that's right.
The electronic reimbursement record. It's really not focused. The focus they want to tell you is focused on the patient and patient-centric. It's focused on the reimbursement.
Yeah, for sure. The technology we have now, there's really no need to ever touch a keyboard or a mouse. I mean, you should be able to sit down there with your patient and talk face to face. That's it. Have everything recorded as you're talking. You have computer vision, natural language processing, everything is there. It's just documenting in the background, supplementing up advice, such as if you do have a question, you can just ask one of these things sitting right there. Utilize the technology we have. Free up the physician's time, and that time that you do have scheduled with that patient, maximize the value in the time slot. And clicking boxes and stuff is not doing it. So I think we should definitely have another conversation about furthering this health operating system idea, because it's something that is steadily growing in my mind of what it needs to be. And I think it does integrate perfectly with Medoplex and kind of the back end operations of managing the patients and the care coordination side of it, really streamlining the whole operation from the beginning of the episode of care to the end of it. So yeah, it's throwing that out there. Probably have another, maybe it won't be a health talk. Maybe it'll just be a non-recorded talk, something like that, if y'all are interested.
Yeah, I'd like to be part of that. I've trimmed down my EHR system significantly, that I use on the back end of my virtual health platform. And the doctors can generally get through it really quick. They don't have to use the ICD-10 codes if they don't want. They don't have to do any of those extra things. So yeah, I could provide some valuable insight into that, and where I think the technology is really going to go as things improve, like integrating AI with the doctor just talking out loud and the computer listening and extrapolating the information that it hears from both the doctor and the patient. I think there's some probably really cool, interesting things we could talk about.
Yeah, I just watched a video, and there was one EHR provider said they will be piloting this first quarter of 2019. What you just said, and the concept of no keyboard, no mouse. So it's there. Like, it's going to start. People will start adopting it.
Yeah. Yeah, you could talk directly into my system too. It'll write it down for you.
Interesting. Cool. Yeah, I'd like to take a look at that too. Well, everyone, for the sake of time, we always try to keep this at about an hour. So I think today was a really good conversation, good talk, a lot of good insight. And this is something that will be ongoing with Medoplex and with Humantive. I mean, these are growing projects. I love hearing ideas. And as a team, we always come together and iterate on these ideas, and it forms what we're building. And this is something that is built for all of us. So we definitely need input from all different experiences. So I welcome anybody that's listening, reach out directly to me. Find my email address easily, brennan@citizenhealth.io, and we can continue the conversation. And also, everybody that's here that hasn't signed up for our forum, we have a forum. It's forum.citizenhealth.io, where we have longer conversations, really start to draw out some ideas. Also, we just launched a chat room, kind of like a Slack clone at chat.citizenhealth.io. That's kind of short form communication. But that's our online community. So we welcome everybody to join that and participate. So does anybody else have anything you want to add?
I just got in, and the last speaker was just speaking about how technology can be cumbersome and difficult, and the technology heard him and cut me off.
That's funny.
I'd like to apologize to the last speaker.
Oh, that's fine.
I'll add one thing is next week I'm going to give a little talk on Twitter for physicians, fresh off the talk at the Mayo Clinic. So I'll be taking some of the ideas from that about how you use Twitter with a focus on mission. And I'll be using some examples from the Mayo Clinic and some of the leading Twitter doctors to give people a reference point.
That would be great. Please feel free to pass that along. I tweet all kinds of good health stuff myself, including my radio show stuff, but I tweet the food that I eat and the exercise that I do so people know what a healthy lifestyle looks like.
That would be an example of mission or ikigai. Megan, I do have an outline for that talk that I could email you at some point in the next few days, and maybe
Please do.
Figure out a way to post it. And but it'll be a fun talk. I might even have a little bit of juggling or some demos here for you. So.
Yeah, that would be great.
So is
email
Epic
address-
sponsoring that talk?
So my first thing is going to be a disclaimer. You know, one thing about these EHR companies, these are good people trying to do good things. I mean, these
Right.
people are doing their best. But you know, the purchasers are generally the CEOs or the COOs, and the systems are designed for the people that are making the financial decisions. So,
Yep.
but I find that most people, most of the time in healthcare, are always trying to do their best, but the system sometimes limits them. So,
I agree.
All right, everyone. Well, thank you for your time today. And same time next week, we'll be doing this with Dr. Rell talking about social media and healthcare. So look forward to that. And everyone have a great evening.
Thank you kindly.
Take
Thanks.
care.
Be
Thanks,
well.
everybody. See you
Great
next
to meet
week.
you all.